I've been in and out my mind since I hit your phone. I've been counting up the times that I did you wrong. I just want you by my side when I get real gone. Feel it's been a little while since we got along. Yeah, we've been playing stupid games, the situation rotates. And they say communication, safe relations, okay. Medicated how I'm patient, wasting time ain't the way. Cause I can see it on your face.
So now, after discussing everything about contraceptives, let us go and talk about the National Family Planning Program, first MCQ. This National Family Planning Program, first MCQ, it is the oldest program that we have in India. It is the oldest program. Please mind it, I'm not saying it is the oldest health program. The first health program of our country is the malaria program. This is the oldest program. In fact, India is proud to say that India was one of the few countries to launch the National Family Planning Program of a mega scale in a country like India out of all the countries. So it was the first country to launch the National Family Planning Program as well. So it was launched in year 1952, the National Family Planning Program. If you just look at the logo of the National Family Planning Program, you can see that there is a husband and a wife, a couple is there, and they are carrying one child. So probably the program focuses, see, I'm not saying that the current goal is this. So probably the long-term goal is to achieve one child, but currently we just have the simple theme that we want two children. So what is the theme under the National Family Planning Program? This can be asked to you in your exam also. The theme is the boy or girl, two will do. It is boy or girl, two will do. That is the theme number one. There is another sub-theme of the program. The sub-theme is to have the second child only after 3 years of first child. So that is the theme, that we want to have a gap of 3 years, and a boy or girl, two will do. That is the theme of the National Family Planning Program. And this is the new logo. Please note, this is the new logo for the national program. If we talk about the World Population Day, it is on 11th of July every year, and the main focus is to promote family planning to increase awareness regarding the burden of population on this planet. So that is about the World Population Day. Next is, what are the targets? See, any program, any national health program that I am discussing with you in any of the videos, you will observe that all the national health programs I will be taking in a specific manner. First, we are going to talk about the target of the program, that what the program needs to do. Next, we are going to see what the program strategy is, how the program is doing it. Third, we will see that what is the organization, like what is the level, who is doing what at what level. And fourth is, what are the monitoring and evaluation indicators. Okay, that's how we are taking every program. So National Family Planning Program is also one of the similar kind of program. What is the target of the program? You've already done this in demography. What is the target of the National Family Planning Program? The target is to have a couple protection rate, that is the operational of the field indicator, to be more than 60%. We also want a total fertility rate to be less than 2.1. Total fertility rate, it is the total number of children that a female is going to bear during her reproductive years, assuming the age-specific fertility rate. That is called as total fertility rate. It should be less than 2.1. And lastly, it is the NRR equal to 1. Why do we say NRR equal to 1? This is the most important impact indicator. It is the best indicator to assess the family planning program at the country level. Why do we say it is 1? It is 1 because we are talking of the NRR as the replacement level. Replacement level. What is NRR? It is the total number of daughters which a newborn girl child is going to bear during her entire life, assuming the fixed age-specific fertilities and age-specific mortality pattern. So these are the targets that you need to know. Next is, what are the strategies that we have under the program? So total, I have combined this whole program into 8-9 strategies. So these are the 4 strategies that you're seeing, and these are another 5 strategies that we will do. So what are the first important strategies? So one is the very big launch of a Mission Parivar Vikas. Beta, please note that Mission Parivar Vikas, this is a 3x5 star MCQ topic for you. What is this Mission Parivar Vikas? Under this Mission Parivar Vikas, we have taken some of the districts. We have taken some of the districts which are actually low performing, and we have tried to put all our efforts into it, all the budget into it to make them perform better. That is what is Mission Parivar Vikas. It is to promote family planning methods. It is to decrease the population explosion in these districts. It's at a district level. So what is the main focus of the Mission Parivar Vikas? That is to have some new things. One of the state I would like to point out over here, Uttar Pradesh, and few other states have also started. That is called as the Nai Pehel Kit. Nai Pehel Kit. So this can be your MCQ. It's a recent advance for you. What is this Nai Pehel Kit? The government of Uttar Pradesh, they were very proactive. It has also been incorporated in West Bengal. They've also started Jharkhand, I think, and Bihar. So in Nai Pehel Kit, it is for all the newly married couples. It is for newly married couples. They will be getting a kit kind of thing, right? So I know it may sound funny to you. So in the Nai Pehel Kit, can you see on the diagram over here that the female is giving some jute bag to another person, right? In that jute bag, there are some contents, like you don't need to memorize the content. There are control pill, condom, mirror, etc., etc. Different things are there, right? So in the kit, basically the kit is to promote what, bache? The Nai Pehel Kit is to promote family planning methods immediately after marriage. Why do we want that the family planning should be there immediately after marriage? We want that the family planning should be there immediately after marriage because we want that the first child should be at least 2 years after marriage. You remember? We talked in demography also that the first child should at least be 2 years after marriage. That is what is a planned family. So we are promoting family planning measures. MCQ, in the Nai Pehel Kit, we are giving condoms. To the newly married couple, they'll get OC pills plus some other female stuff, and that's what is to promote family planning methods and also to promote use of folic acid. To promote use of folic acid, these are all parts of the Nai Pehel Kit. So that is your first strategy, that there is some Nai Pehel Kit and there is a Mission Parivar Vikas. Next MCQ is there is also a Sarthi van. What is this Sarthi van? Sarthi van, it's again a recent advance for you. Sarthi van, these are mobile vans. These are mobile vans which are nothing very special. They are to promote the family planning in these Mission Parivar Vikas districts. So technically MCQ, another can be who is eligible under the Mission Parivar Vikas, which females can be eligible under Mission Parivar Vikas. We can say that age group 20 to 24 years are the main focus in the Mission Parivar Vikas. So, all in all, what is the take-home summary? What is this Mission Parivar Vikas? It is to promote contraceptive use. Mission Parivar Vikas is for newly married couples. Mission Parivar Vikas, the focus is age group 20 to 24-year-old female. Next is there is under the National Family Planning Program, we are proud to say that we have launched some newer contraceptives. So what are the newer contraceptives? I can show these to you. So under the National Family Planning Program, we are proud to talk about the new contraceptives. Beta, this is a 5 by 5 star MCQ topic. It can come in your exam. It's a very important point for your exam. So what are the newer contraceptives under our program? The newer contraceptives that we have is, first, I think you should remember about the Antra. Antra is what? A depomedroxyprogesterone acetate given as 150 milligram of intramuscular injection. Second, we have also started using the new tablets, that is the Chaya tablets. What is Chaya tablets? Chaya tablets is ormeloxifene. It contains 30 milligrams of the centchroman, methoxychroman, and the active chemical is ormeloxifene. That is Chaya tablets. These are the weekly tablets. Third, we have all done these in the previous modules in demography and family planning methods, right? And third is the launch of the Easy Pill. What is Easy Pill? It is use of levonorgestrel 1.5 milligram as emergency contraceptive. So beta, please remember Easy Pill, Chaya tablets, Antra. Plus, very important, we have also started use of the copper teas. Which copper teas? I think you all know it. Copper tea 380A and which another? Please say with me, Copper T 375. What is this Copper T 375? Copper T 375 is the most newly launched intrauterine device under the National Family Planning Program basket. What is this? This is a multi-load device. It is a multi-load device. You remember blue-green color thread and there is no plunger rod and all that. So that is about the copper teas. So please remember, these are the 4 brand new things. What else do we have? We have also started promoting the postpartum intrauterine copper device insertion, that is immediately after delivery, after 10 minutes to within 48 hours. That was postpartum IUCD, right? You remember postpartum IUCD? Next is, we are already giving the Nirodh condoms, the tubectomies, vasectomies, and the Mala N. Along with Mala N, I would like to point out over here that the Mala N is there, plus the Mala D has also been started. You remember, under the social marketing scheme. So these are 5 by 5 star MCQ topics for you. These are the contraceptives which are available under the National Family Planning Program, and I have highlighted which were the new ones. Next is promotion of the PPIUCD. We have already talked about the promotion of the postpartum intrauterine copper device insertion. Next is social marketing scheme. What is the social marketing scheme? Beta, under social marketing scheme, we have tied up with social organization. We have tied up with like the ASHA workers, who's already a health functionary. They will do home delivery of contraceptives. They will do the home delivery of contraceptives. So which are the contraceptives for which they will do the home delivery? Can you see that? So if we just look at what the ASHAs are doing for home deliveries, please note that the ASHA, if you can just appreciate what is written here, I'm talking about the point number 1. The ASHAs will get rupees 1 for a packet of 3 condoms. The ASHAs will also get rupees 2 to rupees 3, depending on the districts or the states, for a packet of emergency contraceptive pill. You remember which pill we are talking of? We are talking of the easy pill or the I pill. In different states, it is taken as different names, I pill or the easy pill. And ASHA will also get rupees 1 for packet of one blister, one patta, one strip of the oral contraceptive pills. So the ASHA is going to get incentives like these. These are the social marketing schemes whereby we want the people to avail more contraceptives from the government of India. Next is, what is this COT scheme, or the compensation for sterilization? COT beta stands for the clinical outreach teams. Clinical outreach teams. Nothing very special, nothing hi-fi. You probably won't get a question on this, but it's just the name I wanted to share with you, that you should know there are COT schemes. So basically, COT scheme is clinical outreach team. We have formulated some teams. They will go and promote family planning methods. So once they are promoting family planning methods, the acceptors of the family planning methods, that is the tubectomy or vasectomy, they should get some money, and the promoters should get some money. So that is what is the compensation for the sterilization. If you just look at the compensation for the sterilization, it's all together different numbers will be there. So we have some high focus states, some Mission Parivar Vikas states, other high focus states and non-high focus states, and some different amount is given to each of them. What I would like you to remember, see, before there was nothing called as the Mission Parivar Vikas, right? And there was nothing called as 11 high focus states. So this topic was not there. We just had the other high focus or the non-high focus, right? But now we have these Mission Parivar Vikas and so many other complications. So there is a very low chance that you will get a question. But just for your satisfaction, I have made a summary table. This is the summary table that you can remember better, if you want to. I'm quite certain that you will not get a question, because these are different state-based schemes. So different states, Odisha will give different money compared to Karnataka, which will give different money compared to Gujarat or Meghalaya or Manipur, right? So anyways, just for your general understanding, please note that in the non-high focus states, non-high focus means these states are already good performing. So we are not focusing on these states. In these states, the ASHA worker will get anything from 150 to 200 rupees for tubectomies or vasectomies, and the user, the person who gets the sterilization done, they'll get anything from 600 to 1100 for for adopting the tubectomy or vasectomy in case of male or female. Common sense, right? In case of high focus states, high focus means these focus are on these. So what could be the high focus states? So you can just remember, I have remembered these high focus states as Bimaru, Koju. So you can just remember it whatever way you want. BI stands for Bihar, M stands for Madhya Pradesh, Maharashtra, A stands for Assam, R stands for Rajasthan, U stands for Uttar Pradesh. C stands for Chhattisgarh. O stands for Odisha. J stands for Jharkhand. And U stands for Uttarakhand. So these are some of the high focus states. So anyways, if you want, you can remember, but as such, it's not so mandatory for you. These states, I would like to tell you, these states are also called as the Empowered Action Committee Group States. These are also called as the EAG state. This can come in your exam. Empowered Action Group States. These are the main high focus states, Empowered Action Group States. But the number may keep on changing, but these are what you need to know as the Empowered Action Group States. So for these states, we are giving different amounts. For these states, we are giving to the ASHA workers 200 for tubectomies and 300 for vasectomies. Plus to the users, it will be slightly more amount for tubectomy, like 600. We are giving 1400. And for 1100, we are giving 2000 rupees. Right, even up till 3,000 in the Mission Parivar Vikas. So Mission Parivar Vikas districts are pretty simple. For tubectomy, we give 2,000. For vasectomy, we give 3,000. That's as simple. But for low focused or non-focused states and high focused states, this is the incentive if you want to remember. So coming back to my strategies, that is what is the clinical outreach scheme or the compensation for sterilization. Coming next is what are the pregnancy testing kits. The pregnancy testing kits, they are by the name of Nischay. Please mind Nischay. It is not Nikshay. Huh? Don't do this mistakes. It's a silly mistake, I would say, if you mark Nikshay. Nikshay is for tuberculosis. Nikshay is for the TB program. Nischay is for the family planning program. These are urine testing kits, urine pregnancy testing kits. These are given free of cost to the females who want to test for pregnancy. That is Nischay kits. Next is this family planning indemnity scheme. What is this family planning indemnity scheme? Beta, please note that people who are getting tubectomized or vasectomized, this family planning indemnity scheme, it's a health insurance scheme given to the acceptors of tubectomy or vasectomy. So what is this scheme? If you just look at the family planning indemnity scheme, this is what is the National Family Planning Indemnity Scheme. It is nothing but a health insurance scheme. It has been given available to the community, to the population or the citizens of India by a bank, that is ICICI Bank. Of course, you don't need to memorize ICICI Bank. The bank may change or not change, whatever it is. So, in fact, we are very fortunate to have an association with the ICICI Bank because they gave the health insurance scheme. So, what is the health insurance? That is what you need to remember. That first is that all the doctors or the nursing homes or the medical centers which are giving the sterilization services, they will be protected for any case of litigation regarding the family planning. Okay, not any case. Regarding the family planning, litigation up to 4 cases a year, including all the lawyer cost and the defense cost, up till rupees 2 lakh rupees for 1 year. In case of death of the acceptor within 7 days, they will get 2 lakh rupees. After 7 days till 1 month. Okay, so for 1 month they will get 50,000. And if the death happens within 1 week, it is 2 lakh rupees in case of death. In case of death, it is 2 lakh rupees within 1 week. And expense of any treatment regarding the medical complications of sterilization, the patient may get 25,000. And for in case of unfortunate case of failure of sterilization, the acceptor is eligible for 30,000. This is what is the family planning indemnity scheme. It is nothing very special. It is a health insurance scheme. It is a health insurance scheme. That is what you need to write in your copies. Next is post-abortion counseling. The government is very proactive. This you must have done during your gynae sessions also, that the government is very proactive that in case of post-abortion, immediate post-abortion, the female should be started on some contraceptive methods. So what are the contraceptive methods? With the timing of abortion, in case of abortion within 7 days, the female can go for option for female sterilization. In case the female wants an intrauterine copper device or a contraceptive device, they can take it within 12 days of abortion. And in case of OCPs, POPs or Antra, that should be started immediately. So these are the methods of contraception which the government of India is promoting after the MTPs or the medical termination of pregnancy. Lastly is, what is this fixed day static approach? That's a very interesting approach. It's a fixed day static approach. So under the Mission Parivar Vikas only, we have started these fixed day static approach. What do you mean by fixed day? That means every health facility, public government health facility in the government of India, the health facility should be observing one day for sterilization. So the district hospital, they should be doing it twice a week, twice per week, 2 times a week. They should be doing it twice weekly. So twice weekly, the district hospital is liable to do the sterilization operations. Sub-district hospitals, it should be weekly. For the CHCs, it can be 2 times in 14 days. So that could be fortnightly. And in case of PHCs, at least 1 month, monthly sterilization operations should be arranged in these using either the doctor or the health facility or the health staff over there, or we can even have the COT scheme, clinical outreach scheme, coming to these smaller PHCs. So that is basically a method to promote the tubectomy and vasectomy among the population, again fixed day static services. So these were some of the strategies that you need to know for the National Family Planning Program. Next is we will talk about organization. As far as the organization is concerned, as we all know, at the center, at the national level, we have the center. Then you have is the state, the district and the village. So you have the center, the state, the district and the village. At the center, we have the Population Advisory Council, which is composed of the secretaries, joint secretaries, additional secretaries. So that will be the governing council, governing bodies. Plus, we will also have a mass media director. So we have a director for mass media because in family planning services, mass media will definitely play a very important role. So then we have the state family welfare bureaus, which are going to manage the district family welfare bureaus. So if you talk about the DFWB, at the district level, we can have 2 different types of the posts. First is the urban health post, that is for small towns. We can have the urban health post, or for larger cities, we can have the urban family welfare centers. For the smaller towns, we can have the urban health post. They can be of 4 types. You can have the post type A, type B, type C and type D. The type A is for less than 5,000 population. Type B is for 5 to 10,000, 10 to 25,000, 25 to 50,000. In the urban welfare centers, you can have the type 1, type 2 and type 3. As you can see on the screen, it is 10 to 25, 25, 50 and more than 50. For larger cities, we definitely need many urban welfare centers. So that is the organization at the district level. That is at the district level, you can have 2 different types of things. That is the urban health post and the urban family welfare centers. Welfare centers is for larger cities and the urban health post is for smaller towns or smaller cities. That is the urban health post. Then at the village level, you have all the health workers, you have the Anganwadi workers who are working for the family planning methods, the ASHA workers, we have the village health guides, the MPWs, everybody is working at the village level. Question number 2. What is a CNAA approach? CNAA means a community needs assessment approach. CNAA, community needs assessment approach. So if you just look at this organization over here back again, rather than the center giving the directions to the state, then to the district and then to the village, rather than it's not a top to bottom approach, it's a bottom to up approach. What do I mean by bottom up approach? That is, the people who are working in the grassroots level, they will see what their population is and they will assess the requirements of the local population that they are working at, and then they will make their own targets. So the local level, the lowest level, is going to make their own targets, and this target is given to the district level. District will give it to the state and then to the to the center level, they are going to do planning and budgeting for the whole National Family Planning Program. So beta, for National Family Planning Program, what is the approach we take? We always take MCQ, a bottom up approach. What do you mean by the bottom up approach? The grassroots level workers, they will make their own targets and they're going to give it to the top center rather than the center telling them that you do this many tubectomies. The village workers will assess that these are the tubectomies they can do and these are the tubectomies they are required to do, and they will just say that this is what my target is and this is shared with the top level. This is what is called as bottom up approach or the community needs assessment approach. Question is CNAA approach is used where? It is used in National Family Planning Program. Point number 3. Under the National Family Planning Program, every year we already had a word that there is a World Population Day. That is on 11th of July. But along with the World Population Day, you should also remember there is a vasectomy fortnight. There is a vasectomy fortnight. Do you remember that what is more important, like from the Government of India health perspective, Ministry of Health and Family Welfare perspective, what is more beneficial to us? Is it the tubectomies or the vasectomies? We had a word on this that vasectomy is more cost effective. One tubectomy is costing like 5 vasectomies you can do for the cost of one tubectomy. So the government is promoting more vasectomy, and if I just show you back again, can you see that the vasectomy will always get more incentive compared to the tubectomies? So anyways, just remember there is a vasectomy fortnight. Why do we have a vasectomy fortnight? To promote vasectomy common sense. When do we have it? It is in the last week of November. Last week of November and the first week of December. This is what is the vasectomy fortnight under this. So all the districts will be organizing these vasectomy fortnights with the help of the grassroots level workers. These are also called as the frontline workers in the family planning program, right? So these are our people who will work at this level. Next is what is the contraceptives which will be available at different levels. If you talk at the village level, that means at the level of the ASHA worker, the Anganwadi worker, or the MPWs or the frontline workers, basically. So if you talk at the village level, please note, all the OC pills, the condoms, they will be available, plus the emergency contraceptive, that is the I pill or the EC pill. Then where will we have the intrauterine devices? Intrauterine devices can be available at the sub-center and above. So at sub-center, the ANM or the MPW female, they can insert IUDs, and even the PHC, CHC common sense, everybody can do. So that was regarding the IUDs, the OCPs, condoms, emergency, and of course the injectables are at sub-center level, the Antara injection. Then if we talk about the permanent sterilization, please note that the PHC, we can have the person, the doctor, MO in charge who's handling the PHC, they should be trained for vasectomy, or they can be even trained for mini lap procedures. But at CHC level, we will have laparoscopic tubectomies. So this is what is the level of contraceptions, like the limiting methods where we will use. You can get a question that emergency contraceptives are available at what level in the organization of the family planning program. Emergency contraception is definitely available at the village level. Next MCQ can be tubectomies using laparoscopic methods. They are available at what level? They are available at the block hospitals, or we can say they are available at the CHCs. CHCs, what is the block hospital, right? So PHCs, we are doing vasectomies or mini lap procedures can be done by a medical officer in charge. So these are some of the things that you need to remember as far as the organization of the program, and this is definitely you need to remember that there are two types of district level categorization. You can have the health center or the health post, or you can have the health family welfare centers in larger cities. Next is sometimes MCQ may also come to you regarding what are the voluntary organizations. Please note that the UNFPA, this is one of the leading organization which has funded our vasectomy programs. So for non-scalpel vasectomies, the UNFPA has come for our help, and they have started the training of the medical officers. They've started with the equipments that are the instruments that are required for conducting NSVs in India has been funded by the UNFPA. Talking about the USAID, they have always been very proactive. The USAID has been very proactive to promote tubectomies, to promote permanent sterilizations, to promote intrauterine devices in the family planning method. So USAID is one another organization. The International Planned Parenthood Federation, the International Planned Parenthood Federation and the Ford Foundation, they are responsible for permanent methods of sterilization, plus the responsible for all the newer temporary methods like the Chaya tablets or the Easy Pill, newer oral methods of contraception in the rural areas. Please note, everything in the rural area is actually Ford Foundation. So IPPF, that is the International Planned Parenthood Federation, is also responsible for implementation of these family planning activities at the rural level. Then you have the Pathfinder Funds and Bill and Melinda Gates Foundation that is working for the IT innovations in our family planning services, the use of mobile apps, use of reminders or things like these. And of course, the World Bank, WHO is funding the whole system. So these are some of the voluntary organizations you would like to remember for your exam. Lastly, so what we have covered till now, we have talked about the TSOI. You remember the target, strategy, organization, and indicators. We have talked about the targets. We've talked about the strategies, the organization, and now we are talking about the indicators in National Family Planning Program. What is the evaluation indicators? The evaluation indicators, beta, can be divided into these 5 categories. We should see that how much is the population, how many are the eligible couples, how many are the target couples, how many are the eligible couples, how many are the target couples, how many people are under 5, how many people are under like 1 year, less than 1 year infants, because this whole family planning is going to be defined by these things. So you should know that how many females are currently using what contraception. So everything like the status analysis has to be done. This is what is the evaluation of the need. Next is evaluation of the plan. These are also called as the process indicator. This is also called as the process indicator. That what is my plan? I want to establish the urban health post. So how many urban health posts are functioning in the district? How many urban health and family welfare centers are working in the district? How many link workers or how many frontline workers are working in your area? So all these are process indicators. How many CHCs are actually doing laparoscopic tubectomies? How many PHC doctors have been trained? All these are my plan. Next is, what is this performance indicator? Performance does not mean the plan, okay? Performance does not mean if I establish an institute, a health facility in my district, if I establish 20 health centers in my district, that's not performance. That is actually the plan that I wanted to implement. The performance will be assessed by how many people are coming to your OPDs, how many people are coming to your family planning clinics. So that is what is the performance indicator. That is how much is the utilization rate. So beta, please remember, this can be your 5-star MCQ topic, that the utilization rates will be assessed by the performance indicator, the plan indicator, the need indicator, the effect indicator, or the impact indicator. Hai na? So try understanding that it's a beautiful concept for you to understand the utilization of the family planning methods. How many females are actually using condoms? How many females have started using the modern methods? How many females are getting the tubectomy done? All these are performance indicators. Along with that, you need to do the cost. Cost is always a big issue in a country like India. So cost is a big issue for us. So that is what is the performance indicators. Then is the effect indicators. How will you find out what is the effect on the population? I'm not talking about the impact. Impact is different from the effect. Effect means, did I change? Did the program change the behavior of the population? Did the people change? Can we do a knowledge, attitude, and practices study? CAP studies. What is this CAP study? Knowledge, attitude, and practices studies. So can we do these knowledge, attitude, practices studies? Like how many people did change their knowledge? How much is the gain in knowledge regarding the family planning services? How much is the attitude change? How much is the practice change? That is what is effect. evaluation. Lastly, which of the following is the most important indicator? Of course, it has to be the impact. Like, what is the impact did this program do on the population? The impact will be studied by common sense, the family size of the family in my district. In Bihar, in Uttar Pradesh, you have a family size of 6 or 7. In many states, the family size is only 4. In many states, most of the country is hanging around with a family size of 5. So what's the family size of average family size? Desired number of children, the birth interval, very important indicator, very crucial for the mother health, is the birth interval. The problem in India, I will discuss in the MCH, is the problem in India is too many things are happening, too many babies are happening, with which is very frequent. That is, too many and too frequent is the word we use. So birth interval is a big headache for the government of India right now. Age of the mother at the first and the last child. Birth order. Many children are born even with a birth order of 6 or 7. That means they already have 5, 6 brothers till the couple is having children. So birth order and number of abortions, all these are going to define what your program did. Did it do good or not good? So all these are important. Which of the following is the most important? The most important is the family size. You remember, we have already talked on this n number of times in the demography module. Which of the following is the most important indicator? It is TFR. What is TFR? TFR stands for the total fertility rate. It is total number of children which a female was going to bear during her reproductive years, assuming the fixed age-specific fertility rates. So the fertility rates are going to define the family size. Family size is given by TFR. TFR is the most important epidemiological indicator. Please note, it is the most important epidemiological indicator. So now just 2 points more before we close this topic on National Family Planning Program, that what is a cafeteria approach and what about the incentives for ASHA. See, we have already talked about the CNAA approach, right? That is the community needs assessment approach. That is a bottom-up approach, right? What is this cafeteria approach? Cafeteria is, let us say that when you go to a cafeteria, the person who stands behind the bar or behind the bench, they don't tell you that you should take drink A or you should take drink B or you should take drink C. You, as a client, will decide that you want to take drink A or B or C. On the similar principles, the cafeteria approach is used where? It is used in the family planning clinics. It is used in the family planning counseling centers or the family planning clinics or the family planning centers. What is this approach? The choice of the contraception is based on the client. It is not based on the service provider. It will be the choice of contraception. The choice of contraception will be based on the client. They will be choosing that I want to take condoms or the barrier or the IUDs or the OCPs, not the service provider. Because the service provider could have some religious issues, could have some personal benefits or whatever, right? So that is what is cafeteria approach. Next is what are the incentives to ASHA for spacing. Now the keyword over here is we are talking about the spacing incentives. So if you just come back to our screen where we talked about the newer incentives, newer approaches in the National Family Planning Program, if I just talk about this point number 2, if I just zoom into the point number 2, that is to ensure birth spacing at least 3 years gap after the first child. Do you remember what was the theme of the National Family Planning Program? That is, boy or girl, two will do. The second theme or the sub theme was that the second child should be after a 3-year gap of the first child. So that is what we have incentives for the ASHA workers. Please note that for the ASHA workers, the ASHA worker will get an incentive of rupees 500. If the ASHA worker will ensure spacing of 3 years to the second child after the first child, ASHA will also get 500 rupees, that if the couple is able to delay the first child for 2 years after marriage. So please note, ASHA will get 500 incentive for delaying first child by 2 years after marriage and for delaying the second child for 3 years after first child. So just remember this. This is pretty important. And of course, we have already talked that ASHA will get 1,000 rupees in case the couple opts for permanent limiting methods up to 2 children only. So these are some of the things that you would like to remember for the National Family Planning Program regarding the approaches, regarding the evaluation techniques and the organization. Next is a couple of questions from the Medical Termination of Pregnancy Act. This is the MTP Act, which was passed in year 1971 with has amendment, major amendment in year 2000 with again major amendment in year 2020. So just remember, these are the MTP Acts we are going to discuss, 1971 with amendment 2020 and 2000. First is, I have simplified the whole program or the protocol for the medical termination of pregnancy into 4 categories. We will need to talk that why can we do MTPs, when can we do MTPs, who will do medical termination of pregnancies, and we will also talk about where we can do the medical termination of pregnancy. So these are 4 terminologies we are going to talk. First is regarding why. Why can we do? What are the reasons which are allowed by the Government of India to conduct the MTPs at various centers? The why can be remembered in terms of the SHEFT, SHEFT. You can remember it. We can talk about the social causes. H stands for the humanitarian causes. Humanitarian causes. E will stand for the eugenic causes. F will stand for the failure of contraception, and T stands for the therapeutic causes, therapeutic reasons. So these are the 5 reasons for which MTP is allowed to be conducted in India right now. What do you mean by social causes? Social causes is where the female is economically or socially not possible for a female to have a baby right now. It could be because she is underage or due to any reason, due to any social reason. The female is not able to take care of the baby. Humanitarian causes means that in case of any unfortunate event of rape or any humanitarian crisis on that female, so that is in terms of rape. Eugenic means that if the medical termination of pregnancy is important because the fetus is not able to survive, the fetus is or the child that she will bear will not survive, fetus not surviving, that is eugenic, some genetic problem. Failure of contraception, common sense, and therapeutic, in which conducting a MTP or the abortion for a female is life-saving. It is life-saving for the mother. In these causes, in these reasons, we can conduct the medical termination of pregnancy. Next is when we can conduct, when to conduct. Earlier MTP guidelines were that within 12 weeks we need 1 doctor, and from 12 to 20 weeks we need 2 doctors. But now it is simple that for within 20 weeks, up till 20 weeks, only 1 doctor is required to give a consent for doing MTP, medical termination. This is what is the update right now. Next is in case of any period of gestation which is more than 20 weeks. In those cases, 20 to 24 weeks also, the MTP is allowed, but only in certain situations. In certain cases, we can conduct the medical termination of pregnancy. Next is who can conduct and where we can conduct. Who can conduct is, please note that any registered medical practitioner who has conducted 25 deliveries under supervision, or is an obstetrician and gynecology specialist. It could be MD, MS Gynae, or it could be DNB also. Or if a person is MBBS with 6 months of junior residency in a government hospital. 6 months of junior residency in a government hospital, common sense in O&G department, not in opthal department or ENT department. MBBS who's done 6 months of residency in gynae department in a government setup. These are the people who are allowed to conduct the medical termination of pregnancy. Next point is where we can do, under what situations we have talked. Now is where we can conduct. The where aspect of the MTP, you can remember it very simple. It can be conducted in any health facility. It could be a public, it could be a private. Any health facility which is government approved and has facility for either a laparotomy. What is laparotomy? That is open abdomen, or the facility for hysterectomy, or a major gynecological surgery, or a major gynae surgery. So that is what is the health facility where we can conduct the medical termination of pregnancy. So for your exam, please note that the when aspect has changed. So earlier it was within 12 weeks we needed one doctor. Now it is still 20 weeks. After 20 weeks, in certain cases like in rape victims, there can be relaxation of the time. After 24 weeks also it is possible. It is now proposed in the government of India that even beyond 24 weeks it can be done, but only after approval from a medical board. But that is only in very restricted situations. For your exam, you just need to remember that within 20 weeks it is only one doctor that we can do, and 20 to 24 weeks it is only applicable in certain situations like in rape. So that's all regarding the medical termination of pregnancy. Thank you so much for watching this module. See you in the next chapter next time. Bye-bye.